So my name is Jiří Mekyska, and in the frame of my talk I would like to tell you something about our research in the field of acoustic analysis of hypokinetic dysarthria in patients with Parkinson's disease. Before I start, I would like to acknowledge our team, our multidisciplinary team. I'm not going to name all my colleagues, but basically it is a multidisciplinary cooperation between our university, it means the Brno University of Technology, Masaryk University, Central European Institute of Technology, and St. Anne's University Hospital in Brno. To introduce myself very quickly, I'm currently the head of the Brain Diseases Analysis Laboratory, which is based at the Brno University of Technology, where we deal with objective and quantitative analysis of neurodegenerative and neurodevelopmental disorders such as Parkinson's disease, dementia with Lewy bodies, primary progressive aphasia, and neurodevelopmental dysgraphia. We focus mainly on acoustic analysis of speech and voice disorders, but also we deal with computerized assessment of handwriting, remote assessment of sleep, and generally with mathematical modeling of medical data. Basically, we provide neuroscientists and psychologists with digital biomarkers that are used for diagnosis, assessment, or monitoring of neurodegenerative or neurodevelopmental disorders. Fine. So today I'm going to talk about Parkinson's disease. I'm sure that all of you know what the Parkinson's disease is, but to give you some more information, Parkinson's disease is the second most frequent neurodegenerative disorder after Alzheimer's disease. And it is caused by a progressive loss of dopaminergic neurons in substantia nigra pars compacta, which is placed in midbrain, and it is associated with several motor features. The most famous and the most frequent features or symptoms are bradykinesia, rigidity, and resting tremor. But also, in some patients, we can observe some other motor features like freezing of gait, posture instability, Parkinson's disease dysgraphia, and also hypokinetic dysarthria. So hypokinetic dysarthria is a motor speech disorder that is manifested in the field of respiration, phonation, articulation, and prosody. And to give you a better intuition about this condition, I will play you, or I will show you a short movie that is part of our protocol. At the beginning of our assessment protocol, we ask the patients, what are your hobbies, where do you come from, etc., to get some free speech. Sorry, can you play the movie? You see that she's not expressing any emotions. This is called hypomimia. Then her speech is not very loud. There is monopitch, poor articulation, late response, etc. So there are many specific disorders that you can actually identify in patients with Parkinson's disease. Not all PD patients have hypokinetic dysarthria, just up to 90%, and not all the patients have the same pattern of hypokinetic dysarthria. So unfortunately, hypokinetic dysarthria has very detrimental impact on patients' quality of life. So we try to diagnose it as early as possible so that we can introduce an effective intervention. For this purpose, nowadays, mostly we use perceptive analysis. I mean, speech-language therapists or pathologists are assessing these speech disorders. But also we can employ the acoustic analysis. And today I would like to show you what is the benefit of the acoustic analysis in the field of treatment monitoring and in the field of prediction of motor and non-motor deficits in Parkinson's disease. So let's start with the first part, and that's the treatment monitoring stuff. So nowadays, the most frequently used treatment of Parkinson's disease is pharmacological using levodopa. Levodopa is precursor of dopamine, and it has very beneficial effect on cardinal motor symptoms like this rigidity, bradykinesia, etc. But regarding the effect on speech, the conclusions are quite inconsistent. You can find publications claiming that it has a positive effect on speech. You can find publications claiming that it has a neutral effect on speech, etc. Probably The effect is very individual. It depends on the progress of the disease and probably also on the subtype of Parkinson's disease. Anyway, in our analysis, we always consider medication as a confounding factor that we try to remove, for instance, using linear regression. The second approach of Parkinson's disease treatment is invasive. It's called deep brain stimulation. And in the frame of this stimulation, we use some electrodes implanted in subthalamic nucleus or globus pallidus interna. And these electrodes regulates abnormal electrical signaling pattern in the brain. But unfortunately, when the surgeons, let's say, insert these electrodes, they care much about the cardinal motor symptoms such as resting tremor or bradykinesia. But I don't want to say that the effect on speech is not that important, but sometimes it's neglected. So you can find publications, again, concluding that it could have positive effect on speech, it could have neutral effect, but also a negative effect on speech. Yes, so as I already said, the most frequently used treatment approach is pharmacological. And since the effect on speech is very controversial, we try to find another approach of treatment of speech disorders in Parkinson's disease. And this approach is based on the so-called repetitive transcranial magnetic stimulation. Repetitive transcranial magnetic stimulation is non-invasive and painless stimulation, where the neuroscientist place a magnetic coil over a specific scalp and modulate cortical excitability. Using RTMS, we are able to, let's say, stimulate the brain up to 2 centimeters beneath the scalp, but also in some interconnected and more distant parts of brain. Theoretically, the effect of RTMS stimulation could last for months. And let's say 5 years or 6 years ago, when we started or when we entered this field, there were some pilot studies. One of them was our study, where we proved that the single session of 10 Hz RTMS applied over the left orofacial primary sensory motor area may improve the voice quality and tongue movements. And also there was another study published by Murdoch et al., who proved that repeated sessions of RTMS could have some positive effect or impact on speech in PD patients as well. So at those times, we formulated a question, and that is, what is the most beneficiary combination of target regions of brain and the stimulation settings? Because you can use 1 Hz stimulation, 10 Hz stimulation, etc. So in this study, we enrolled 16 PD patients with mild to moderate hypokinetic dysarthria as assessed by speech-language therapists. And in each of these patients, we applied 5 sessions of RTMS at each time with different settings. I will explain this here. So before the stimulation, we sent a patient for a scanning in magnetic resonance, and during this magnetic resonance imaging, we recorded speech. So we were able to correlate acoustic features with the changes of activity in brain. After that, they underwent the RTMS stimulation of the right superior temporal gyrus, vertex, and primary orofacial motor area. We used 1 Hz and 10 Hz stimulation. After the stimulation, after 30 minutes of the stimulation, we scanned the patient again, and he performed the same speech tasks, so that we were able to compare the differences before and after the stimulation. Regarding speech tasks, during the magnetic resonance imaging, they read 48 neutral sentences, and unfortunately, magnetic resonance imaging is very noisy, so we were limited in terms of features. Moreover, I'm very happy that today Jean-François mentioned interpretability. In our field, the interpretability, the clinical interpretability is even more important. I entered this field more than 10 years ago, and I have speech processing background. My master thesis was focused on speaker identification or verification. So at that time, I came to neuroscientists and tell them, okay, we have some features that are very good, that have very good discrimination power. Empirical mode, decomposition, nonlinear dynamic, polyspectral features, they work well, but then they ask me, okay, and what does it mean from the physiological point of view? And I didn't know. So then I limited all these thousands of features to maybe 10 or 15. But features that I'm able to interpret from clinical point of view. And that is very important. In that scenario, since there was very strong noise, I was limited to quantification of monopitch, inappropriate silences, and rigidity of tongue and jaw. So here we have some results. We proved that 1 Hz RTMS of the right superior temporal gyrus had positive effect on articulation and generally on legibility. And this has been proved or confirmed by a speech-language therapist as well. And in fact, it makes sense because the right superior temporal gyrus is responsible for auditory feedback. And it is well known that the speech of PD patients is altered also due to the fact that they do not perceive themselves correctly. So we probably somehow improved this auditory feedback so that they perceive themselves in a better way. Fine. Of course, this study has some limitations. First of all, we enrolled only 16 patients, but you have to keep in mind that this protocol is very demanding. We have to repeat the sessions, and there are some inclusion-exclusion criteria, and also this research is very expensive because we need to employ magnetic resonance imaging, etc. Actually, this field of speech processing, I don't want to say that it's completely different to automatic speech recognition, but you know, when we talk about a cohort of patients, then we talk about 20, 50, up to 100 patients, but definitely not about thousands of patients. So you need to take or consider all the results that I'm going to present very critically. Okay? As I said to some of my colleagues today, I call this work like doing a precision guesswork with unreliable data for those with high expectations. So we have to be careful with some general conclusions. Yes, so we proved that the RTMS stimulation has some positive impact on speech. We proved that objectively using acoustic analysis. But of course, in the second step, logically, we try to check whether it has some longitudinal effect as well. In this study, we enrolled 33 PD patients, 20 in the real stimulation and 13 in the so-called sham stimulation group, let's say placebo group. We stimulated patients for 10 days, and we chose this right superior temporal gyrus. And except for, or let's say besides the acoustic analysis, we examined the patients using some neuropsychological scales and scores, etc., prior to and then after these 10 days, and then repeated after 4, 8, and 12 weeks. In this case, we performed the acoustic analysis outside the magnetic resonance imaging, so we were allowed to use a more complex protocol and to use more features. So our protocol consists of this monologue, like what are your hobbies, where do you come from, how do you feel, etc. Then they read a phonetically balanced text they sustained some corner vowels. We used sustained phonation of A to measure respiration. Then we use one task, it is called diadochokinetic task, where the PD patients pronounce pataka, pataka, pataka very quickly to assess articulation. And then they repeated 10 polysyllable words. Regarding the dimensions of hypokinetic dysarthria, we try to quantify almost all specific speech and voice disorders that are common in patients with hypokinetic dysarthria. Not all of them, but almost all of them. So such as airflow insufficiency, increased noise, tremor of jaw, monoloudness, monopitch, some articulatory features, etc. This study is not finished yet. We are just working on a publication. But we have some preliminary results, at least based on perceptual analysis, where we proved, and this is already published, that we observed some improvements in articulation, prosody, and speech intelligibility. And these improvements sustained for several weeks. So that is very nice. And as I said, we are just working on the acoustic analysis. And also, I think last year, our colleagues from Prague published one very interesting publication where they found out that, as I already mentioned, not all PD patients have the same type of hypokinetic dysarthria. Some PD patients have the so-called, or let's say, prosodic subtype. Some of them have phonatory prosodic, some of them have articulatory prosodic. So we would like to explore this effect. We would like to stratify the patients into these groups and then to explore the effect in each group separately. This finding also addresses, let's say, a hype in our field, because you can identify many publications claiming that you can identify Parkinson's disease just based on sustained phonation. This is very controversial. From my point of view, it's I don't want to say nonsense, but it's not that easy, because not all PD patients have hypokinetic dysarthria, and not all patients with hypokinetic dysarthria have dysphonia. Okay, so we need to combine much more features and have more complex and better insight. That was just a very quick comment. Yes. So that was RTMS stimulation. But then COVID came, and it was necessary to have something that we can perform at home. RTMS stimulation is very expensive, and you need the patients to visit clinic, okay? Because at least in our scenario, you have to fix the head, and you have to target the part of the brain based on magnetic resonance imaging. We use a special targeting device, so it's very complicated for administration. So we try to explore something new that we can perform at home. And we were very lucky because we received a new grant that started 1 month ago, and that is based on transcranial direct current stimulation in combination with Lee Silverman voice treatment, which is a behavioral treatment approach. The difference between RTMS and TDCS is that RTMS theoretically trigger an action potential in underlying neurons, while the TDCS enhance the probability of firing an actual potential. This could look a little bit strange because you are letting electric currency into your head, but actually it's very safe because we are talking about 0.1 up to 2 milliamperes. It's easy to administer and it's not that expensive. This behavioral treatment will be delivered via let's say Skype, Zoom, whatever. And the study will be split into 2 phases. In the first phase will be conducted or performed in clinic, where we will find the optimal parameters of this transcranial direct current stimulation. And then in the second phase, we will used the at-home monitoring using repeated sessions of this TDCS in combination with LSVT load. So this is something very new. Hopefully in next 1 or 2 years we will have some preliminary results. Fine. So until now I was talking about the utilization of acoustic analysis in treatment monitoring, but it has some other interesting applications. One of them could be used to predict other motor features of Parkinson's disease, more specifically gait difficulties. In some studies, it has been proved that freezing of gait and hypokinetic dysarthria are both axial motor symptoms of Parkinson's disease, and that they share some pathophysiological mechanisms. Based on this finding, we asked whether using just acoustic analysis of hypokinetic dysarthria, we are able to predict whether the PD patients will develop some gait difficulties. More specifically, we had these 3 questions. So, first of all, what is the relationship between hypokinetic dysarthria and gait difficulties? What dimension of hypokinetic dysarthria is more associated with gait difficulties, and whether we are able to predict these gait difficulties. So for this purpose, we used a cohort of 75 PD patients. 41 of them were recorded twice with a 2-year gap. So regarding the assessment of gait difficulties, we used very frequently used freezing of gait questionnaire that has 2 parts. We focus on the second one, which is more quantitative. It has these 4 questions. Regarding speech acquisition protocol, we use this complex protocol again, where we have monologue, some expiration tasks, diadochokinetic tasks, some reading tasks, etc. These are specific disorders that we were quantifying. So again, for instance, aperiodicity, airflow insufficiency, monoloudness, monopitch, unnatural speech rate, etc. Using very simple measures like fundamental frequency, jitter, shimmer, some formant frequencies, etc. Regarding statistical analysis, we used partial correlation, where we controlled for the effect of age, gender, levodopa equivalent daily dose, which is the information related to medication, UPDRS score, assessing motor abilities of PD patients, back depression inventory, because we try to remove the effect of depression, and a cognitive scale. In terms of prediction, we employed gradient boosting algorithms. So here are some results. Generally, we identified that in PD patients there is a relation between speech articulation and these gait difficulties. More specifically, if the patients have gait difficulty, then probably, or most probably, they have also a kind of articulation deficit or poor intelligibility. In terms of prediction, using these machine learning models, we were able to predict a change in the scores assessing gait, with error coming or ranging from 7% until 14%, depending on a specific gait or freezing of gait disorder. So in this study, we really proved that there is a connection between speech and gait in PD patients. In another study, we tried to explore whether, again, just based on acoustic analysis of speech, we can predict cognitive decline in PD patients. Because there was one publication from 2009 claiming that there are probably some relations between speech and cognitive functions in PD patients. So the question is, or was, whether we can use these acoustic parameters to predict cognitive decline in PD patients in 2-year horizon. In this study, more or less, we used the same cohort of PD patients that were recorded twice with a 2-year gap. In terms of clinical examination, more specifically in terms of cognitive functions, to assess them, we used Addenbrook's cognitive examination questionnaire, and we stratified PD patients into 3 groups: PD patients with normal cognition, PD patients with mild cognitive impairment, and PD patients with dementia. In terms of speech tasks, we used reading of a paragraph of some sentences and then poem recitation, and we quantified monopitch, monoloudness, unnatural speech rate, and inappropriate silences. I will skip this and go to the results. Generally, using just one acoustic feature, we were able to predict whether a patient will develop cognitive decline with 73% accuracy, more specifically with 87% sensitivity, but with quite a low specificity. This feature is quantifying, it is a temporal feature, and it is quantifying interword pausing. Actually, it is number of interword pauses per minute. So probably temporal alterations in speech are somehow connected with cognition in at least in PD patients. When we combined this acoustic feature with a score assessing rapid eye movement sleep behavior disorder, we slightly improved the sensitivity. Fine. So I presented some applications of acoustic analysis of hypokinetic dysarthria, and the question is maybe why is it so beneficial or why is it so important? Yes, so nowadays PD patients, at least in the Czech Republic, visit hospital once or twice per year, which is highly insufficient. The disease could be very dynamic. We need to adjust treatment and improve their quality of life. Nowadays, when they have some issues, some side effects like hallucinations, whatever, they call neuroscientists that they have some issues, and using this, let's say, telemonitoring, but it's not really telemonitoring, but just discussions, they are trying to adjust the medication. But of course, this is very subjective and inaccurate. So we need a technology that is theoretically able to monitor PD patients 24 hours per day, and that could possibly notify neuroscientists, speech-language therapists, or psychologists that something is happening and that they should intervene. For this purpose, we can use smart devices like smartphones, smart TVs, assistants, smart assistants, etc. These devices will enable us to do this kind of individualization. So in terms of speech, let's say that we would like to monitor this speech remotely. The first key player that entered this, let's say, market or the field, whatever, was Apple a few years ago. In cooperation with one company which is called Sage Bionetworks, they developed an app that had several, let's say, tasks, and one of them was this sustained phonation. Unfortunately, just sustained phonation, but at least there was something. But the issue is that in terms, or let's say in the case of this application, the PD patients have to interact with this very actively. And this is a limitation, because if you ask the PD patients to repeat some tasks for 1 week, for several months, there will be very high drop of effect. So we need something that would be passive. And our colleagues in 2017 introduced a very nice app. It was called Atkinson, that you just installed on your smartphone, and well, a smartphone. And when a PD patient was calling someone, then automatically his speech or her speech was processed, and some features were delivered to speech-language therapists, neuroscientists, etc. But since new versions of Android is not that easy, of course, due to some privacy issues, etc., it's very challenging. Nowadays, our team has another idea, and that is to use smart assistants. I will tell you why. There was one study, I think it was in Netherlands. It was not connected with Parkinson's disease, but generally with smart assistants, where they equipped senior people, I mean those living alone, with smart assistants, and they really fell in love with them because they had somebody they can speak to. They got some response. They didn't care that it is artificial intelligence. They were very happy that they have somewhere to speak. So that's another opportunity how to get speech in a passive way. Of course, this is very challenging field, not just due to background noise, but also due to speaker diarization, etc., etc. So let's say that this is maybe future. Let's see. And of course, again, it's not that very easy to get inside this black box, because of course Google, Amazon has everything secured. So I had some discussions with the development team of Google, and they are not really willing to make it open. Let's see. Fine. Probably the last remark is linked with generally with the path. I'm a researcher, so I do the research, I find something interesting, hopefully, let's say, and then I leave the commercialization to other people because I don't want to spend years of my time, money, etc., etc., etc. And actually, there is still a long path until integration in clinical practice, because when you develop such a tool, you have to follow some guidelines regarding digital endpoints, like, for instance, recommendations from Digital Medicine Society or the recommendation of CTTI, World Health Organization, etc. Also, today, you have to make your tool patient-centric. It means that you have to involve patient organizations during the whole process of development. This is very important, and for instance, FDA or EMA cares a lot about this. And after that, as soon as you have a tool that provides meaningful outcomes, that is easy to use, and that provides outcomes that are meaningful for PD patients, then the worst is about to come, and that's the certification from FDA or EMA. And this can take several years. And after that, you maybe find out that your technology is already outdated. So it's very challenging, and if we have someone from the industrial part, then I'm really crossing fingers. Yes, so the last comment is that even though it's very challenging, I believe that in next few years, hopefully, we will have some meaningful technology, not meaningful just for neuroscientists and engineers, but mainly for the PD patients themselves, so that we have a better impact on their quality of life. And that's, with that, I would like to thank you for your attention.